and welcome to the teaching session of Department of Urology, Savai Mansingh Medical College, Jaipur. So today we have a teaching session on medical management of urinary stones. This would be presented by our resident, Dr. Sandeep Desai, and this would be moderated by Dr. Dharmendra Jangid, who is our faculty. I would request all others to please mute yourself. And today's faculty is Dr. Nilesh Jain. So Dr. Nilesh Jain is a professor and head, Department of Urology at Kota Medical College, a very good friend of mine, and he is definitely very good at academics, no doubt. He developed the Department of Urology at Kota Medical College. But again, there are a few more qualities with him which I would just like to highlight. One is he is very good in yoga. He's a yoga expert. And secondly, he is very good at sports. So even probably at this age also, he plays cricket and badminton regularly, and he has taken part in so many interstate and inter-college championships also. He has won a lot of awards in that also. So welcome, Nilesh. Thank you for joining our teaching session today.
Thank you, sir. Thank you.
And today we have also with us a surprise faculty, Dr. Sanjeev Mehta. Dr. Sanjeev Mehta is a dedicated person, doctor in the medical management of stones. He has his own laboratory which does metabolic evaluation of stone formers. And we are really glad to have Dr. Sanjeev Mehta with us today. So thank you, Dr. Sanjeev Mehta, for joining us. And I would request now Dharmendra Jangid to please invite the presenter and go ahead.
Good morning, sir. I request Dr. Sandeep to start his presentation.
Good morning, respected teachers, seniors, and my colleagues. Today I am going to present medical management of renal calculi. Sir, here is my presentation.
Yeah, just make it full screen.
Sir, conservative medical management of renal calculi.
Dr. Sandeep, can you make it full screen, please?
Sir, it is already full screen showing in my screen.
This is not. If we just make it again, maybe. Again, share your screen with full screen.
Sir, is it full screen now?
Yes. Go ahead.
Sir, medical management of renal calculi. Sir, today I will present conservative management, medical management. Sir, there are three main points: fluid recommendation, dietary recommendation, and obesity. Sir, in fluid recommendation, volume, forced increase in fluid intake to achieve at least a urine output of 2 liters. It has two effects: mechanical diuresis that prevent urinary stagnation, and formation of symptomatic calculi, and creation of diluted urine, which alters supersaturation of stone component. Now, sir, water hardness. Although water hardness can alter urinary parameters, but it doesn't play a significant role in recurrent risk. Sir, carbonated beverages. Carbonated water offers increased protection against recurrent stone formation by decreasing urinary citrate levels. Soda flavored, which with phosphoric acid, may increase the stone risk, whereas those with citric acid may decrease the risk. Caffeine intake may increase the risk of stone recurrence in calcium stone former by increasing excretion of calcium. Sir, citrus juice are in citrus juice, particularly lemon and orange juices, may be useful adjunct to stone prevention. Sir, dietary recommendation for medical management. or prevention are increase protein restrictions. Incidence of renal stone is higher with increased animal protein intake. Protein intake increases urinary calcium oxalate, uric acid excretion, and probability of stone formation. Diets high with fruits and vegetables imparts a significant reduced risk of stone formation than high in animal protein. So sodium restrictions, important element of dietary prevention of recurrent nephrolithiasis. Sir, high sodium intake increases calcium excretion, urinary pH, and decreases citrate excretion. And net effect is increased propensity of calcium salts in urine. Animal protein restriction, moderate calcium ingestion, reduced sodium diet, decreases stone episodes by roughly 50%. Sir, calcium stone formers who ingest large quantity of dietary salts are more likely to suffer from decreased bone mineral density also. In dietary calcium, sir, moderate calcium intake in stone patient. Dietary calcium restriction may increase oxalate absorption also and leading to calcium oxalate supersaturation. Safe calcium supplements, and then time to be taken with meals, and calcium citrate stone friendly calcium supplement. Sir, vitamin D supplement. Vitamin D depletion is likely safe for stone formers. However, 24-hour urine calcium should be monitoring during vitamin D therapy. Bisphosphonate combined with thiazide appear to reduce hypercalciuria while protecting bone. And vitamin C in larger dose increases stone recurrence, but limited dose 2 gram per day is recommended. Sir, oxalate avoidance, foods with high oxalates, then tea, cocoa, spinach, mustard green, beets, rhubarb, berries, chocolate, nuts, peppers, etc. food should be avoided. Sir, in obesity, increased BMI and larger waist size and weight gain correlates with increased risk of stone episodes, more pronounced in women's. And metabolic syndrome, hypertension, hypertriglyceridemia, glucose intolerance, central obesity, and obesity and insulin resistance cause impaired ammonium excretion and cause low urinary pH and increase risk of uric acid stones. So now medical expulsive therapy for renal stone. So there is some guidelines for medical expulsive therapy in which medical expulsive therapy is efficacious for treating patient with ureteral stone who are amenable to conservative management. The greatest benefit might be among those with more than 5 mm distal ureteric calculi. So in proximal and mid-ureteric calculi, there is no significant benefit of medical expulsive therapy, or also for non-obstructive stone, there is no significant advantage of medical expulsive therapy. Sir, level 1A evidence is present for alpha blockers increase stone expulsion rates in distal ureteric stones more than 5 mm, and also class effect of alpha blockers has been demonstrated. So recommendation is offer alpha blocker as medical expulsive therapy as one of the treatment option for distal ureteric stones more than 5 mm. Is strongly recommended. Also, there is use of calcium channel blockers and phosphodiesterase inhibitor 5, also used in some places, but alpha blockers are superior to both of them. Sir, commonly used agent for medical expulsive therapy are alpha blockers, calcium channel blockers, nifedipine, and phosphodiesterase type 5 inhibitors like tadalafil. But sir, tamsulosin showed overall superiority to other drugs. Sir, when to stop medical expulsive therapy? If complication like infection, refractory pain, deterioration, renal function, etc. develops, then we have to stop medical expulsive therapy. Sir, conservative management summary is with conservative management alone, a significant number of patients may be able to normalize their urinary risk factor for stone formation. These conservative measures may be necessary to keep their stone disease under control, and after 3 to 4 months on conservative management, patients should be re-evaluated. Sir, if patient having metabolic or environmental abnormalities have been corrected, the conservative therapy can be continued and patient followed every 6 to 12 months with repeat 24-hour urine testing as indicated. If, however, a metabolic defect persists, a more selective medical therapy may be instituted. Sir, general diet advice are oral fluid intake to achieve urine volume more than 2 or 2 to 5 liter per day. Circadian fluid intake, dietary calcium intake of 1000 to 1200 milligram calcium per day. So limit sodium intake less than 2300 milligram per day or less than 100 milliequivalent per day. If urinary oxalate is elevated, limit high oxalate foods and increase fluid and vegetables and fiber. So limit non-dairy animal proteins like red meat, poultry, fish, etc. So now in selective medical management. So this is algorithm for overall all type of stone space management. Sir, in this, after basic evaluation and 24 urine evaluation, treatment of all type of stones is here. Sir, in hypocytraturia, alkaline citrate to be given. Hyperuricosuria, alkaline citrate and sodium bicarbonate with or without allopurinol. Then, sir, hyperoxaluria, we have to give increased dietary supplemental calcium magnesium, and if more than 80 milligram per day, then increased dietary and supplemental calcium magnesium B6 and for primary hyperoxaluria. Sir, for hypercalciuria, if it is more than 200 milligram per day for female and more than 250 milligram per day for male, then we have to see for PTH if it is normal or raised. Then if normal PTH, then we have to give alkaline citrate with or without thiazide, and in raised PTH with calcium. If by primary hyperthyroidism confirmed, then parathyroidectomy to be done. For cysteine stone, hydration is important, and urine pH more than 7 to 7.5 and tighter with alkaline citrate and sodium bicarbonate with or without tiopronin. For hypomagnesuria, magnesium supplement to be given. Urine volume, if less than 2 liter per day, then we have to increase oral fluids, and urine sodium is more if more than 150, then low sodium diet is advised. So calcium based calculi are occur if hypercalciuria more than 200 milligram per day. There are three types: absorptive, renal, and resorptive hypercalciuria. For absorptive hypercalciuria, absorptive hypercalciuria type 1 and type 2 is there. Increased urinary excretion of calcium in both fasting and loading specimen, and in type 2 elevated urinary calcium on regular diet, normalize on fasting. So normal PTH due to suppression from constant abundance of available serum calcium. So treatment of absorptive hypercalciuria in type 1, thiazide is first choice with potassium citrate and dietary restrictions. Thiazide do not treat underlying cause of absorptive hypercalciuria, but reduce urinary calcium and manage its symptoms. Mechanism of action is thiazide directly stimulates calcium resorption in distal nephron while promoting sodium absorption. Side effects are potassium wasting, muscle cramp, hyperuricosuria, intracellular acidosis, hypocytraturia, etc. So sodium cellulose phosphate. Sodium cellulose phosphate decreases absorption of intestinal calcium. Thiazides are limited long-term effectiveness in absorptive hypercalciuria type 1. Other hypocalciuric agents like indapamide, amiloride with thiazide, and triamterene. Sir, age type 2, no specific drug needed. Moderate calcium intake 400 to 600 milligram per day, and high fluid intake sufficient to achieve minimum urine output of more than 2 liter per day. Avoidance of excessive sodium intake further decreases hypercalciuria. Sir, now dietary brands. Sir, rice bran binds to intestinal tract and increases urinary pyrophosphate, and thiazide plus bran superior to bran alone. Now, sir, renal hypercalciuria due to wasting of calcium by functioning nephron. Sir.
Sandeep, go ahead.
Yes, sir. Sir, in renal hypercalciuria, due to wasting of calcium by functioning nephron, constant loss of function, loss of calcium from distal tubules, and hypercalciuria during all phases of fasting, loading or restriction of dietary calcium. Sir, mild elevation of PTH also, intake PTH also. Treatment of renal hypercalciuria is thiazide is treatment of choice with potassium citrate, and correction of hypokalemia and increased urinary citrate. Thiazide corrects renal leak of calcium by augmenting calcium reabsorption in distal tubule, and by causing extracellular volume depletion, and stimulating proximal reabsorption of calcium. Correction of secondary hyperthyroidism, and restores normal serum 125 dihydroxy vitamin D concentration, and intestinal calcium absorption. Sustained correction for up to 10 years. Sir, potassium citrate supplement to be given 40 to 60 milliequivalent per day is advised. Avert hypokalemia and increase urinary citrate when given to patient with calcium nephrolithiasis taking thiazides. Now, sir, resorptive hypercalciuria in primary hyperparathyroidism, overproduction of PTH from dominant adenoma or diffuse hyperplasia. Hypercalcemia and hypercalciuria occurs in all phases, and parathyroid is raised. Treatment is parathyroidectomy. Resection is dominant. Resection of dominant adenoma or all four glands. No established medical treatment is there. Orthophosphate used only when surgery cannot be undertaken. Now, sir, hyperuricosuric calcium oxalate nephrolithiasis. Uric acid more than 800 milligram per day, or and hyperuricosuria when pH is more than 5.5. Causes are increased dietary urine intake, gout, multiple myeloma, neoplastic states, pernicious anemia, hemoglobinopathies, thalassemia, pernicious anemia, etc. So treatment is decreased dietary protein intake, and allopurinol also decreases uric acid production by inhibit xanthine oxidase. So potassium citrate also alters urinary milieu in hyperuricosuria by decreasing supersaturation of uric acid, and calcium oxalate also. Sir, hyperoxaluria is when urinary excretion of oxalate is more than 40 milligram per day. It is of type 2, of its type, enteric hyperoxaluria and primary hyperoxaluria. So in enteric hyperoxaluria, fat malabsorption results in saponification of fatty acid with divalent actions such as calcium and magnesium, thereby reducing calcium oxalate complexation and increasing the pool of available oxalate for reabsorption. It caused by diarrhea, dehydration, bicarbonate losses, associated with chronic diarrheal states, small bowel resection, jejunal bypass, and intrinsic disease. So treatment of enteric hyperoxaluria is oxalate restricted diet, so high fluid intake and antidiarrheal agents, uh, probiotics like ornithine formigens, potassium citrate, correct hypokalemia, metabolic acidosis, and increase urinary citrate, oral calcium citrate or magnesium gluconate, and cholestyramine, which binds with bile salts in bowel. So now primary hyperoxaluria, it is a rare autosomal recessive disorder of glyoxylate metabolism. So normal glyoxylate to glycine conversion is prevented, and preferential oxidative conversion of oxalate. So it is having three types. Sir, pH1, pH2, and pH3. So treatment of primary hyperoxaluria type 1 is primary hyperoxaluria treatment is pyridoxine for type 1, present during childhood with early stone formation and tissue deposition of oxalate and renal failure due to nephrocalcinosis. Commonly, death occurs before 20 years in untreated patient, and early diagnosis and combined liver kidney transplant done. Hypocyturic calcium oxalate nephrolithiasis. So less than 150 milligram per day in female and less than 450 milligram per day in male. So distal renal tubular acidosis type 1, having hypokalemic, hyperchloremic, non metabolic acidosis, and abnormal collecting duct formation, inability to acidify urine more than urine pH more than 5.5. Calcium phosphate stones are most common. 2/3 patients having nephrolithiasis and nephrocalcinosis, and infants will present with vomiting and diarrhea and growth retardation. So children presents with renal stones and metabolic bone disease also. So causes of distal renal tubular acidosis are obstructive uropathy, recurrent pyelonephritis, acute tubular necrosis, renal transplant, analgesic nephropathy, sarcoidosis, primary hyperparathyroidism, etc. Treatment of distal renal tubular acidosis is potassium citrate. It corrects metabolic acidosis and hypokalemia in a distal renal tubular acidosis. Large doses up to 130 milliequivalent per day may be required in severe acidotic cases, and target dose in children is 3 to 4 milliequivalent per day per kg in divided doses. So thiazide induced and idiopathic hypocytaturia is its treatment is potassium citrate therapy. So for hypomagnesiuric calcium nephrolithiasis, so low urinary magnesium, hypocytaturia, and low urine volume, chronic thiazide therapy, irritative bowel disease or inflammatory bowel disease causes malabsorption and laxative abuse. Treatment for hypomagnesiuria is magnesium supplement. Use of magnesium is limited by risk of diarrhea, and potassium magnesium citrate may restore urinary magnesium and citrate levels with minimum gastrointestinal side effects. So uric acid calculi. Uric acid is end product of urine metabolism. At more acidic pH, undissociated uric acid predominates and precipitates. At higher pH 6.5, more than 90% of uric acid is ionized and dissolved. Sir, four main determinants: low urine pH, low urine volume, hyperuricosuria are there, and gouty diastasis refers to stone forming propensity characterized by low urine pH of unknown etiology with or without gouty arthritis. So treatment in treatment, major goal to increase pH more than 5.5, preferably between 6 and 6.5. Alkalization to a pH more than 7 should be avoided. Risk of urine because risk of calcium phosphate stones formation. Potassium citrate therapy and allopurinol if hyperuricosuriia or hyperuricemia is present. Chemolysis for uric acid stone. Sir, mainly oral chemolysis is used. Stone composed of uric acid stone but not sodium or ammonium urate stone can be dissolved by oral chemolysis. Prior stone analysis, urine pH measurement and X-ray characteristic may provide information on stone composition. It is based on alkalinization of urine by alkaline citrate or sodium bicarbonate. pH should be adjusted to 7 to 7.2. And chemolysis is more effective when it is effective at a higher pH, which might, however, promote calcium phosphate stone formation, but no RCT are available for this therapy. A combination of alkalization with tamsulosin can increase frequency of stone passage of distal uric acid stone as shown in one RCT for stone more than 5 mm. Now, so cystinuria, sir, it is autosomal recessive error involving intestine and kidneys. Inability to reabsorb dibasic amino acid and cysteine, ornithine, lysine, and arginine, also called COLA. Resultant accumulation of cysteine causes crystallization when concentration rises above the saturation point, above more to 250. Young age commonly at a young age. So treatment is to reduce urinary concentration of cysteine to below its solubility limit. High fluid intake to produce 2.5 to 3 liter per day of urine, and urinary alkalinization by potassium citrate. So restricted salt and sodium diet and use of cysteine binding agents increase cysteine solubility in urine via formation of more soluble mixed disulfide bond. Mercaptopropionate glycine, it is most commonly used. Side effect of its are asthenia, GI distress, rash, joint aches, and mental state changes. D-penicillamine also used, and captopril also used sometimes. Sir, for infective calculi, struvite stones form in alkaline pH more than 7.2 and with infected urine with urease producing bacteria in an ammonium-rich environment. Sir, more common in women. Staghorn calculus are also common, and symptom of UTIs are present. So treatment is mainly surgery, but in medical management, acetrohydroxamic acid, which is urease inhibitor, reduces urinary saturation of struvite and retard stone formation, shown to prevent recurrence of new stone and inhibit growth of stones in patient with chronic urease splitting infections. Side effects are thromboembolism, tremors, headache, palpitation, edema also. Sir, chemolysis. Sir, for struvite stone, percutaneous irrigation of chemolytic agent is used, but nowadays it is rarely used. May be an option for infection stone and theoretically also for uric acid stone. For dissolution of struvite stones, Sebi's G solution 10% hemiacidrin of pH 3.5 to 4 can be used. So ammonium acid urate stones, so infrequent and often associated with laxative abuse. Medical treatment for this calculi is determined by underlying cause. Those with laxative abuse are encouraged to develop healthier bowel habits, and those with chronic infection are treated like those with struvite calculi. So medication-related stones are calculi formed from drug which are indinavir stone, ephedrine, trimetharin, magnesium trisilicate antacid, and sulfamethoxazole trimethoprim drug-related stones. Sir, calculi provoking drugs are calcium anhydrase inhibitor, topiramate, furosemide, vitamin C in excess, vitamin D in excess, and laxatives. Use of this drug should be limited. to prevent drug-related stones. Sir, medical management of bladder calculi. Sir, stone dissolution using SEBI G or M solution is beneficial in irrigating indwelling suprapubic or urethral catheter to decrease and prevent encrustation and occlusion. Irrigation with acetic acid solution for prophylaxis against struvite calculi when catheter must be left indwelling for long period. Uric acid calculi may be dissolved by irrigation of alkaline solution in bladder. So for neonatal nephrolithiasis, neonate with furosemide induced stone present with hematuria, worsening of renal function and calcific density on USG or X-ray. Nephrocalcinosis is often present on imaging studies. Cessation of furosemide diuresis is considered helpful and standard therapy. Suggestion that treatment with thiazide diuretics may actually promote the resolution of this process and reverse the likely parenchymal injury. Children and adolescent nephrolithiasis dietary recommendations are similar to those for adults, and important to emphasize that dietary calcium is not to be avoided in this age group. Rather, calcium should be sought through the ingestion of dairy and other natural sources rather than with use of supplement. Such sources will also bind dietary oxalate during meals and may decrease calcium oxalate supersaturation in urine. Sir, medical management of calculi in pregnancy is due to temporary physiological changes. Metabolic evaluation is not undertaken to determine the cause until delivery and return to baseline health status. Majority of ureteral calculi during pregnancy spontaneously pass. Sonography or limited IVB to be done. Treatment is hydration, analgesics, antibiotics, stents if required. Thank you, sir.
Thank you, Sandeep. Please ensure your presentation. And now I would
Yes,
request Dharmendra to kindly invite our expert faculty. Nilesh, you can go ahead with your comments, please, and then we will have an interaction.
Thank you, sir. First of all, I would like to congratulate Sandeep for his nice presentation. Actually, as a surgeon, we all know it's a theoretical topic, and what is in our hand basically is potassium citrate with magnesium and pyridoxine. And it holds true for almost every stone for the prevention. We don't have anything else because until unless we go for metabolic analysis and the stone analysis, we cannot conclude that which therapy needs to be given specifically, particularly in the cystine stone or the uric acid stones. Definitely, I would like to add a point that medical expulsion therapy, I think it is basically for stones of less than 6 mm rather than more than 5 mm, because more than 5 mm is not having any limit. It does, and also it doesn't mean that less than 5 mm we cannot use the medical expulsion therapy. But definitely the presentation is very good, and I would like to congratulate again to the Dr. Sandeep, and best wishes to the Department of Urology at SMS. Please go ahead. Thank you.
Thank you, Nilesh. Thank you, Nilesh, for those comments, particularly of the medical expulsive therapy. Yes, definitely. Less than 6 or maybe even less than 8 millimeter stones can be tried, and according to the guidelines, even less than 10 millimeter stones have a possibility of being expelled spontaneously with the help of this therapy, though the incidence would be very low in that case, but definitely 5 to 6 mm stones have a chance of 90% expulsion. So, Dr. Sanjeev Mehta, would you like to say anything?
Yeah, right. Thank you, Shivam bhai. I would like to just read, means the primary goal to treat a stone disease patient is to take the steps to prevent the further recurrence of the disease. Because we know stone is known for the recurrence, and before starting treatment, one should think and rule out the what could be the preventable cause of stone formation. Because stone we consider as a idiopathic, but there are chances that there are many other diseases like hyperparathyroidism, and there is a number of diseases which are primarily responsible. And if we treat those causes, the stone recurrence can be prevented. Now, if we have to achieve our goal, means everything, like, because I'm from my faculty, I would like to put emphasis. The patient should be properly investigated. One is the field is the routine blood and urine test. Like if we find out even the proper pH is done of that urine, it can give clue to whether it's a infective stone or it is a uric acid stone. So all those, even sometimes the renal tubular acidosis can also be suspected based on the some primary basic test. Another, because I have to keep it brief, another is the, as you said, the stone analysis, because a small piece of stone can give clue to, it can have many stories, means. Then there are certain types of stone which can be diagnosed only by stone analysis, not by any other means. Like for example, uric acid stone or steroid stone, and there are some rare stone also, xanthine for example. And then it comes to the 24 hours urinary metabolic profile, which is very, very important. Because everything, like we have seen in discussion, hyperoxyluria or hypocyturia, how it should be treated. But generally what happens, one should not go for non-specific kind of treatment. Means a patient is advised for everything. Unless we measure all those things, if we find out whether there is actually there is hyperoxyluria or hypocyturia, then accordingly we can plan our line of treatment. So all these things are measurements. Even supersaturation index can also be now measured. So our goal is to downgrade, to bring the supersaturation index to the normal values, and it depends on all other parameters like uric acid, oxalate, citrate, even pH and urinary total volume also. So those things should be dealt. Unless we measure those things, we cannot find out. To sum up, there are 5 steps to prevent the stone recurrence, which is achievable. It's not a myth that stone cannot be prevented. First, one should know the crystal. What is the composition of stone? And there are many things can be find out. Time is not enough to take these things in details. Then obtain proper blood and urine measurements. One, screen for the systemic disorders if they are present. Then measure 24 hours urine, all the metabolic profile with supersaturation. Start your treatment. First objective is to lower by half the supersaturation of urine. And if we find out that supersaturation has come down by measuring, then we need to evaluate. We can consider patient has now entered in a stage where it can be prevented, or even the recurrence can also be delayed. If still those values are high, then keep on measuring every after 4 months till it becomes normal. Once all those values are normal, because it's a stone management prevention is a long-term therapy. Then if everything, all parameters are normal, then it should be measured annually to do a proper follow-up, whether patient is compiling or whether patient is being adequately taking treatment to prevent the further recurrence of stones. That is why I want to add, sir. Thank you.
Thank you.
But
Thank you,
presentation
Dr.
was very good and it was well prepared.
Thank you. Thank you, Dr. Mehta. It was really kind of you to have joined the session, and definitely you have elaborated on the importance of prevention and preventing the recurrence of these stones, because the incidence of stones is worldwide increasing. The various studies have shown that it's almost 124 per lakh population, and the lifetime risk of developing a stone in Middle East countries is around 20 to 25%. And in other Western countries, it's around 10 to 15%. So it's a very highly prevalent problem, and definitely the incidence is increasing. And the recurrence of the stone, once they have formed, would be around 50% in 10 years, as it was said. But recent studies have shown that even in 5 years, there can be a recurrence in 50% of these patients. So I think we should take it more seriously now. And we definitely do the surgical management of urinary stones, but prevention and preventing the recurrence would be even more important, I think, to reduce the mortality, morbidity of and the suffering of these patients. If any of the, I've just put up these AUA guideline statements, which are, there are about 27 guideline statements. All those who are viewing can just go through these guideline statements also. In the meantime, I would request any of the faculty members or residents, if you have any query, please go ahead. I think there are a few senior urologists also with us, Dr. Anil Jain, and we have our faculty, Dr. Nachiket, Dr. Neeraj.
Sir, good morning, sir.
Good morning. So any comment from you people? Yeah.
Yes, sir. Just a form of an observation, sir. I remember when I started practice in 2009, I remember a young person coming to me who was a recurrent stone former, and he was inside the bank. So at that time, being lecturer, bubbling with knowledge, and he was asking me about how do I prevent my stone formation, and I was telling him everything about low sodium, restrict sodium to 2.3 gram, calcium restricted to 1200 milligram, animal protein restricted to 0.8 gram. So one thing that he asked me, which has stuck my whole life, is that, see, you are telling me restriction of calcium oxalate stones, but tell me, how do I practically do this? Now, how do I practically come to 1.2 gram per day of calcium? How do I measure that amount of calcium? How do I measure the amount of protein? You are asking me 0.8 gram per kg body weight per day. So he had very, practical, suggestions to make. So I think that everything is very good on paper, and being, calcium oxalate being the most common stone, I actually didn't have any answer. See, you have told me that your vitamin C should not be more than 100 milligram per day. But the thing is that many of our patients coming from rural, so actually how I think that we can just tell them the broad, restrictions, what they should do and what should not do. But however, it's even for people who are educated, it's very difficult to restrict all those things. I mean, on the paper it looks good. How to measure 2.3 grams of sodium restriction and calcium sodium? I mean, I didn't have answer for many of the things that he was asking, and he literally gave me a good life lesson. And he was saying that, tell me, you are telling me to restrict the vitamin C to 95 milligram a day. Tell me, how do I do that? So many things sometimes inside these things look very good on paper, but I think that for these patients, we can just go for important generalizations. And I think that should be this life lesson that I had from that patient, was that we can generalize, but sometimes becomes difficult for these patients.
Thank you, Nachiket, for that, bringing out that point. Most of us probably would not say that restrict to this milligram and that milligram. But if you are, definitely you have to give the answer to the patient. So usually what we do is to ask them to reduce the intake of sodium, the sugar.
Yeah, sir. This was inside my practice, sir. जैसे मैंने बताया,
Right.
2008 में मेरे practice में आ गया था. So then I just give generalization these days, and जितना follow patient कर सकते हैं. I think it's easier for very specific conditions like cysteine या uric acid के लिए तो फिर भी easy हो जाता है. But most common stones, calcium oxalate, dihydrate, monohydrate. Even जो Crow study है, that says that despite all restrictions, 70% of patients will recur in 10 years. So we have to do our best because we want the patients to be stone free, but sometimes it becomes difficult for the patients also.
Right. So basically what we usually, because 90% here in India is calcium oxalate, and uric acid could be the actual initial promoter. So we usually ask them to have a vegetarian diet, and followed by
Yeah,
less
sir. वो
of
तो सब
sodium.
पता ही है, sir.
Yeah,
जी,
that's true.
जी.
So that's the usual recommendation.
Absolutely, sir.
So the fluid intake again is very important, so that
Yeah,
the
most
EU
important.
guideline
Yeah.
says that
Most
if you have
important,
to have
sir.
at least
Yeah.
2 to 2.5 liters of urine output per day, the
जी,
amount
जी.
of fluid should be
जी.
almost equal to that. Any
जी,
comment
sir.
from Dr. Sanjeev? And then, yes.
Yes, sir. In spite of all the
About the exact values, whether should we just tell the patient that you should restrict your sodium to this much amount, calcium, maybe
sodium
नहीं, वो
calcium
तो
should not
possible
be
ही नहीं है,
restricted,
sir.
definitely.
Possible ही नहीं.
Yes,
and calcium, I think generally,
not
in my
restricted.
experience, there is no need to restrict. Rather, sometimes restrictions, if patient is taking
Cause more.
calcium,
Yes.
can produce more stones.
Yeah.
So
Definitely.
general the calcium intake, milk, people stop taking milk if they have, you might have seen in practice also. So adequate calcium should be given. Salt restriction and plenty of oral fluid, means water, is I think it's the key. One
Right.
should go for in spite of any stone. But if we do on if we measure and we do stone specific treatment, then it has been studied that 60% of patients, they come with recurrence. If we do non-specific therapy, the recurrence rate is 60% within next 3 years. But if proper parameters are measured and we do therapy accordingly, then the incidence comes down to 15 to 20% also. So if we find any other facility, one should go for the measurement and accordingly patient should be treated.
Thank you. Dr. Nilesh, any comment from your side?
Very true. Actually, what I wanted to say, Dr. Nachiket has told, because it is really impossible to tell the patient regarding the restrictions. Broadly, it is must. I will say, rather than plenty of fluids, I think it is be capping enough fluids, because illiterate and they are more emotional regarding the fluid intake. So once they are start taking the fluid, they used to take 7 liter, 10 liter, even 15 liter. So the problem with the bladder also there. So there should be enough fluid which will be enough to produce the 2.5 liter urine output, because more than 2.5 liter, it has been clearly written that after 2.5 liter, there is no decrease in the incidences and increase in the passage of the stones spontaneously. So 2.5 is the capping, and it is basically between 2 to 2.5. So I would say that it is enough fluid intake rather than the plenty of fluid. And second thing is that dietary restriction, definitely dietary restriction, it is very, very difficult to implement. And we just say that stop added salt. That is the most important point. Stop added salt. And second thing is we can have a vegetarian diet, particularly the non-dairy proteins like red meat and all should be avoided, preferably avoided. Otherwise, definitely it is very difficult for a patient to understand that how can I stop the how can I prevent the stone recurrence? Usually, it is a myth that all the seed producing vegetables and the spinaches, they blankly stopped it. But unless we have a clear metabolic analysis and stone analysis, and we put all the things together, and we found that this particular disease is running, we cannot specifically tell that this needs to be stopped. Thank you, sir.
Yeah, thank you. Thank you, Nilesh, for the point, bringing that point that excess of fluid may not be helpful. And even when you do an overhydration, we know people used to put IV fluids and overhydrate the patient. And usually the patient would have more pain because of the increased probably back pressure and because of increased dilatation of the PCS and ureter. So definitely overhydration and over enthusiastic fluid intake would not be helpful in these patients. Moreover, it also dilutes the citrate in urine. So it produces rather hypocitraturia if you are doing over enthusiastic fluid intake. And again, fluid intake should be in the form of mainly in the water or juices, citrus juices, not tea, coffee, or carbonated beverages, which are probably counterproductive. So it's very important to ask them to take more of water and maybe some citrus juices and
In fact,
lemonade.
I would like to add that the fluid intake should be periodical like water should be drink every hourly.
Yes.
Patient
Yes.
should not get thirsty.
Yes,
It
yes,
should not
circadian.
be in one go. Patient generally takes 2 liters of water, drinks, and then whole day nothing.
Yeah.
And obviously, over drinking is also an issue because sometimes patient produces 7.5 liters of urine. That is also true, sir.
Right.
Can be
Thank you.
harmful, sir.
Thank you. So I would request now our moderator, Dr. Dharmendra, Jangid, you if you have any comment, otherwise just give a vote of thanks.
On the behalf of urology department, I would like to thank Nilejan sir and Sanjeev Mehta sir for sparing their precious time and sharing their valuable experience with us. Thank you, sir. Thank you all.
Thank you
Thank you
much.
very much.
Thank you,
Thank you
Dr.
very much.
Nilesh. Thank you, Dr. Sanjay Mehta, and all the faculty members. So I will just conclude the session by saying that medical management of renal urinary stones is a very important thing because the incidence prevalence of stones and recurrence is increasing day by day, and the management basically consists of one is the acute treatment in for medical expulsive therapy, in particularly distal ureteric stones. Patients who have underlying systemic diseases should be treated accordingly, and patients who have recurrence or are in risk or under risk of recurrence should be treated after doing a proper metabolic evaluation of these patients. So thank you once again. Thanks everybody who have joined today, and have a good day and a happy Valentine's Day to all of you. Thank you very much.
Thank you, sir. Thank you, sir. Same to you, sir.
Thank you.
Same to you all. Thank you.
and have a good day, sir.
Thank you.
Okay. Ah.